Dr. Sakaris. And thank you for asking me to present our findings at this press briefing. So I'm presenting on behalf of Amy Kirkwood, who's in the audience, and she'll be presenting the oral presentation this afternoon. So just to set the scene, acute lymphoblastic leukemia is the most common cancer of childhood, the most common leukemia of childhood, has an excellent cure rate with modern risk-stratified treatment, but has considerable toxicity, which results in between 5 and 10% of children dying off their treatment, and a significant minority also having both acute and late side effects, which result in a poor quality of life and high burden of care on the families. And the other issue we're still dealing with is that when they do relapse, about half of the relapses involve the central nervous system compartment. So the trial in question was trying to address these two issues of toxicity and relapse within the central nervous system, and I had a complex stratification, as do all trials of acute lymphoblastic leukemia in children, which resulted in 3 risk groups: a low-risk group, an intermediate risk group, and a high-risk group. And this stratification was based on a combination of age, white cell count, and the genetics of the leukemia. First question was, if we were to give a shorter but higher dose course of the most optimum steroid, dexamethasone, during the first month of treatment, would it cause less toxicity than our standard schedule of 28 days? And this was to detect a 5% difference in a composite toxicity endpoint, which included treatment-related deaths as well as significant steroid-related side effects. The second question was in 2 parts, what we call R2 interim maintenance, which compared high-dose methotrexate, which has for a number of years, 50 years, been thought to be important to prevent relapses within the central nervous system, although it hasn't been standard custom and practice within the United Kingdom protocols. So we decided to test that against our standard interim maintenance, and here we were trying to reduce the rate of relapse involving the nervous system from 4 to 1.5%. And the third was also a toxicity question. The standard treatment of acute lymphoblastic leukemia involves a prolonged 2 to 3 year phase of primarily oral chemotherapy, to which on the UK and American side, we've added in pulses of vincristine and 5 days of dexamethasone, whereas our European continental partners have not. So we tested whether the UK backbone could result in the same outcome without the pulses, and thereby reduce the toxicity that's associated with them. And this was what's called a non-inferiority study, where we were trying to reduce toxicity without affecting the relapse rate. So we recruited a total of 2,750 patients. We have a median follow-up of 76 months. For a variety of reasons, some patients we excluded from the randomizations, and we ended up with 1,900 patients randomized to the steroid question, and 1,570 patients that were randomized to the 2 R2 questions, the interim maintenance and pulses questions. The steroid randomization was closed early, and so after that, all patients received the standard 28-day schedule, but were still randomized to the R2 question. So in brief, we did not, unfortunately, see a lower toxicity with a shorter schedule. which interestingly is still the standard schedule in the US for children under the age of 10 years. And the results of the second randomization, the R2, were highly confounded by interaction with the first randomization, which has made analysis of the results very difficult. And Amy has to be congratulated that she's tried to bring out some messages. One, which is very clear, is that it unfortunately did not reduce the risk of CNS relapse, but may have some benefit in reducing the risk of relapse within the bone marrow for some subgroups of the B-type acute lymphoblastic leukemia, which is the more common type in children, but is associated with toxicity, with delayed clearance of the drug in 60% of patients and renal toxicity in a minority of 1.7%. The omission of pulses did not increase the relapse rate within the boundaries of non-inferiority margins, which was 5%. So there was a difference, but it was less than 5%. The difference was in favor of pulses, but it was not significant because we were only powered to detect a 5% difference. There was a hint of benefit for the overall event-free survival benefit, but that was complicated by the fact that we saw a higher rate of secondary cancers in the children who did not receive pulses, which we are struggling to explain to a biological basis for. There was, again, an excess of toxicity, primarily infections and neurological toxicity associated with the pulses, and we had an add-on study looking at patient-reported quality of life and burden of care outcomes, which we have yet to analyze, but I'm pretty sure it'll show that the pulses in high-dose methotrexate are associated with an impact on quality of life. So in conclusion, the trial did not give us the answers we were looking for, but that's why we do randomized trials. And at least we have one clear answer, which is the high-dose methotrexate does not seem to have benefit in reducing the risk of CNS relapse. And thank you, I'll stop there.